So this is the second placental installment, and the purpose here is to show how the three-dimensional topography of fetus and placenta correlates with the two-dimensional slides that the pathologist looks at. And so first let's consider the umbilical cord. And in considering the umbilical cord, I want to call your attention to the fact that the lining of the fetal skin is continuous with the lining of the umbilical cord, and then reflects really at the fetal membranes as the amniotic layer of the fetal membranes. So skin, umbilical cord lining, and amnion are all one in essence, except this is a transition zone, and it's a squamo-columnar transition zone, and anyone who looked at a newborn baby's belly button would understand that, yes, would immediately recall that, yes, there is a transition zone there, and it's a squamo-columnar transition zone. So let's consider what a pathologist looks at when she's looking at a cross-section of the umbilical cord. So because of that continuity that we spoke about, remember this continuity between the umbilical cord and the skin and the amnion, it's not surprising then that the outer lining of the umbilical cord would be what? You guessed it, amniocytes. And so these cells are amniocytes. And then, running within the matter of the cord are the fetal vessels that are delivering fetal blood to the distal villi for gas exchange with the maternal circulation. And so, we see two umbilical arteries and one umbilical vein. And the way to distinguish the umbilical arteries from the umbilical vein is, number one, the muscle cells or myocytes within the media of the umbilical arteries have a more concentric arrangement. In other words, they're more in layers, whereas the vein is more haphazard. And in addition, there's like a condensation of elastin right underneath the intima, and that's called the elastic lamina. And then the other thing that I find when I look at sections is that the intima, which is the subendothelial or subendothelial connective tissue in the arteries, is a little bit more developed, and that's probably because they have to handle shear stress. And then the other thing in the umbilical cord, the other natural constituent, is what makes up the center of the cord, and it's sort of like shock absorber material, because the baby is sitting there turning pirouettes, moving, and he needs some stretch, he needs tension, he needs mobility in his cord, and that's Wharton's jelly, and it's made of proteoglycans, and there's like little fibroblasts, and as the fetus gets a little bit older, Wharton's jelly starts to collagenize a little bit. And the other thing I'd call your attention to is that sometimes we see some developmental remnants within the umbilical cord. So one of the remnants that we see, it always exists between the two arteries, and that's a urachal remnant. And the reason the urachal remnant is between the two arteries, if you think about the fetal side of the equation, here's the fetal bladder, and the bladder tapers up and runs really into the umbilical cord in the portion called urachus. And what runs right beside the urachus? The two umbilical arteries. And so you could imagine, if it persists in the cord side of the equation, then you get these remnants. And if the urachus persists in the fetal side of the equation, you could get a patent urachus, and even sometimes the baby experiences weeping of urine through the umbilicus. So this is a remnant within the cord side of the equation, and this would be the remnant. There's another way you could see the remnant within the fetal side of the equation. And the other remnant that you less commonly see within the umbilical cord is the vitelline duct remnant, or omphalomesenteric duct. And if you imagine here the fetal intestine, and a certain distance from the ileocecum, there's a duct that comes out, and that's the vitelline duct, and it runs into the umbilicus. And so if it persists in the fetus, that's what we call a Meckel's diverticulum. If the fetal portion doesn't properly involute, that creates a Meckel's diverticulum. But let's say it does involute, but this portion, the portion within the umbilical cord, doesn't involute, then you get a vitelline remnant, which isn't a big deal. These are just embryological vestiges, and they're relatively innocuous. So as I'm dictating this video, I have a very bright student here, and she asked me morphologically what distinguishes, if you're looking at the slide, what helps distinguish a urachal remnant from a vitelline remnant. And because the bladder is lined by transitional epithelium, sometimes or often the urachal remnants, if you look at them very carefully, they look transitional in nature. So that's another tidbit. So moving on, remember one of the things in the topography of the placenta that I really wanted to call your attention to is that the layer of extravillous trophoblast cells that I've showed here in the stippled green the layer of extravillous trophoblasts are continuous with the chorion. In fact, they really are the chorion. The chorion is very similar to the extravillous trophoblast. And in fact, you could sort of think that embryologically, initially, the placenta went all the way around the fetus. But what happens is, in embryology, for most of the placenta, for this portion of the placenta, the villi involute. And then what happens is the amnion basically comes into direct contact with the underneath, which is these extravillous trophoblasts, and your villi just get removed. They get cut out of the equation, and this goes here, and that's what creates the fetal membranes. And then underneath everything is a decidua, and so too here is decidua, but this we call decidua capsularis, and this we call decidua basalis. But if you imagine that we just delete the placenta, then we really get amnion sitting right on top of extravillous trophoblast, but in this context we call it chorion. And that's really the structure of the fetal membranes. But you actually can see embryological vestiges of these involuted villi, and that's what you see with these senescent villi. Senescent villi. So in other words, involuted villi. So then let's have a consideration of what the cross-section of the fetal membranes look like. So on top, pointing outwards or pointing towards the amniotic cavity are your amniocytes or amniotic cells. And they are relatively organized, cuboidal to columnar cells. So they're basically cuboidal, low cuboidal to columnar cells, depending on how irritated they are. And underneath that, we said we have the chorion, which is very similar, as we said, to extravillous trophoblast cells. And they're pretty distinct. And sometimes you see here this, which is sort of my way of showing a senescent or regressed what? Villus. Because the placenta used to go all the way around. And these, this and this, are fetal. And then beyond that, you have maternal parts. So this is maternal. This layer. And what this is called is the decidua. But because it's the decidua around the fetal membranes, we call this the decidua capsularis. So this is the decidua capsularis, the maternal decidua around the fetal membranes. And that's made up of these cells that have bright pink eosinophilic cytoplasm, and for the pathologist, sometimes because these cells are quite plump and these cells are quite plump, they look similar, and sometimes it's a little bit hard to distinguish the two. But what these really are, these decidual cells, are, they're in a way almost luteinized endometrial stroma. So if you say, well, if that's endometrial stroma, can you see the glands? And the answer is, if you're very careful and you look really carefully, sometimes you could actually see the endometrial glands. But I've left them out because they're not crucial. But what I do want to point your attention to is what you do see when you look in the decidua capsularis are these thin-walled vessels. And they're so thin-walled you won't recognize them for what they are. They actually are arteries. And you could say to me, but David, how do arteries get so thin? Where's the muscularis? Where? And the answer is that these arteries have been what? They've been remodeled. And they've been remodeled by the fetal trophoblast to create a low resistance circulatory bed. So these are the remodeled spiral arteries. And in fact, in certain pathological states, they could be too thick, and that would equal pathology, and some of the types of pathology that relate to maternal hypertension and diseases such as preeclampsia. So what I'm saying is that these thin-walled spiral arteries, when you're looking at the decidua capsularis, give you a window into the maternal circulation. And so the placenta is a structure that tells me about the fetus, and it also tells me about the mother. So just like when you're on an obstetric service, they always say to you fetal factors, maternal factors, placental factors, so too for the pathologist looking at histological sections of the placenta, you have a window into fetal factors, maternal factors, and then factors that are really truly placental factors. And with that, we'll end this lecture.